speak. So hello everyone, welcome to our webinar on family planning, which is all about navigating fertility, pregnancy and postpartum care. So the webinar will provide an overview of the unique considerations and challenges that people with MS may face when planning a family. So I am delighted to introduce you to our speakers, Daisy Cam and Kate Petheram. So Daisy is a lead MS specialist nurse at Sheffield Teaching Hospitals NHS Foundation Trust. Daisy has a particular interest in MS and women's health, including pregnancy and menopause, and she's spoken at national and international conferences on these topics. And Kate is a consultant neurologist with a special interest in MS, working in Sunderland. And she also has a particular interest in MS and women's health. She is a member of a stakeholder group aiming to improve care for MS patients navigating the menopause. So I feel very lucky to have them both here today to deliver this webinar. And yeah, just thank you both so much. And I'm now going to pass on to you and mute myself for now.
Hi everybody, my name's Daisy. Thank you, Amy, for inviting me today, and thank you for your introduction. We are going to skim over really because we only have a limited amount of time and we could talk about this for hours. So we're just going to touch on the basics of family planning and MS. If you could move the next slide for me, Kate, that would be great. Lovely. So the learning objectives tonight is firstly understanding MS and fertility, how MS may or may not affect your fertility. We're going to address some of the misconceptions and concerns about getting pregnant when you have MS. We're going to go through, or Kate's going to go through all the MS medications and pregnancy, the impact on what you can and can't take during pregnancy and when you're trying to conceive, and any effects that the MS treatments have on fertility. And also how to adjust any medications, particularly the DMTs before pregnancy. We're going to go over how MS may affect your pregnancy and vice versa. We're going to discuss the role of disease-modifying therapy treatments during pregnancy and the potential challenges in MS symptom management during pregnancy. And also we're going to go over postpartum care, so once you've had your baby, and family planning post-delivery. Next one, please. So myth busting. So in my line of work and Kate's and most MS teams, there's always historically been a lot of myths surrounding pregnancy and MS, most of which are completely incorrect. So we're just going to go through some of the very common ones. This is a quote from Rachel Horn. Rachel Horn is a medical journalist. She's on LinkedIn. And she has an interest in gender and ethnicity in the diagnosis and treatment of neurological conditions. She has a real interest in MS particularly, and she is a research fellow and a patient advocate. And this is a very recent quote that she heard, and you can read it for yourselves. This patient was told that she shouldn't have kids because she's got MS. And Rachel has said, which is absolutely what we would go with as well, there may be challenges. Supporting you is absolute key. But having MS doesn't and shouldn't stop you getting pregnant, being a great parent, and you should absolutely not be discouraged from this major life experience. So this is the first of the Slido questions. So the first question is, have you ever been told that you can't have children or shouldn't have children because of your MS? And if you click onto the Slido, whether it's yes or no, it'd be really interesting to see how many of you have been told one way or the other.
We've got lots of votes coming in already. So I've also put the link to the Slido. If the QR code isn't working for you, I've put the link in the chat as well. So at the moment, we've got 88% no and 12% yes.
Good. That's great. That's the answer we want, but we really don't want any of the 12% either. So things are changing in the field of MS, and but it is very dependent, I think, still on your particular MS team, where you are in the country. The NHS, as we all know, is not equal around the country, and I think depending on your neurologist, and sometimes you may not even have an MS nurse, so knowledge is sometimes not correct. But the 88% of you who have been told no, yes, even is absolutely right. So the second Slido question is, have you been told you can't have MS treatments if you want to start a family?
So that question is now live for anyone that wants to take part in that. We've got lots of votes coming in. I'll just give it a few seconds. Great. Thank you everyone for voting. So we've got 84% no and 16% yes. So a bit
Great.
higher on that
Again,
one.
that's swaying the right way, but again, we shouldn't have anybody that's been told that they can't have MS treatments because of wanting to get pregnant. We'll touch on that further on. So these are the facts. MS does not affect fertility in itself. The MS disease modifying therapies also do not affect fertility. It's really important if you're planning a pregnancy to discuss this with your MS team before getting pregnant, ideally, regarding the DMT that you're on. Drugs for fertility treatment also do not adversely affect MS. And that's something that if people are struggling to get pregnant, we would absolutely encourage them to go down the infertility clinic route. So the next Slido questions, should you have a cesarean because you have MS?
That one is now also live for anyone that wants to take part. So this one, I have also added a not sure option because I'm actually not sure. So I did that for my own benefit. Thank you everyone for voting. I'll just wait a little bit longer. Right, so that is 11% yes, 26% no, and 63% not sure.
Okay, that's great. I'll go on to discuss that on the next slide. But the next Slido question, should you have extra scans because you have MS whilst you're pregnant? And I mean, sorry, by scans, I'm not talking about MRI scans, I'm talking about baby scans, pregnancy scans.
Okay, lots of votes coming in. Again, I added a not sure option for people. So we have got 30% yes, 45% no, and 25% not sure.
Okay, let's go on to the proper facts on the next slide. Please, Kate. Okay, you do not need to have a cesarean because you have MS. Absolutely not. We do try and encourage our ladies to have a vaginal birth. It's a much quicker recovery and it's much better for baby and mum. Obviously, there may be medical reasons why a cesarean is advised, but it should not be purely on the grounds of having MS. Next slide, please. And you absolutely do not need extra growth scans because of the fact that you have MS. Pregnancy with MS should be treated as a normal pregnancy, and unless medically indicated, there's no need for extra tests or scans. And I think these are the last of the myth busting. So, should I take blood thinners during pregnancy due to having MS? Yes or no? Or don't know?
Yeah, I also added a not sure to this one. Votes are coming in. Thank you everyone for voting on these. So we have got 0% yes, 85% no, and 15% not sure.
Okay, lovely. And can I have all pain relief during labour, including a spinal? Yes, no, don't know.
Okay, votes are coming in. Oh, it's coming in very fast. Thank you, everyone. Okay, we have got 67% yes, 6% no, and 28% not sure.
Okay, let's go on to discuss. No, you do not need to take blood thinners during pregnancy because you have MS. There's absolutely no reason. What we use in Sheffield, we work alongside the obstetric team, and the obstetric team in Sheffield, and I don't think it's the same across the country, but certainly in South Yorkshire and Sheffield, the midwives and the obstetricians use what's called the Tommy's app. And what happens with that is when you're booked in, your previous medical history is taken, your family history is taken, your previous pregnancies history is taken, and it comes up with a score. And because MS comes under the category of uh, uh, come on, Kate, help me out.
Autoimmune.
Oh no, it's the one. It's been a long day. An autoimmune disease. That option is clicked on, and that sometimes comes up with needing aspirin or blood thinners. It's absolutely not the case at all. Again, I think this is some obstetricians who are not clued up with neurological conditions do give their ladies aspirin or blood thinners, but it's absolutely not necessary. So you can absolutely have all the pain relief in labour, including a spinal, and having a spinal will not affect your MS. Your pain threshold may be lower compared to the general public due to fatigue if you suffer with fatigue as a symptom. But absolutely take all the painkillers offered. So the effects of childbirth on MS itself. Childbirth itself does not alter the course of your MS. Depending on how long your labour is and how tired you may become, it may take you longer to recover from the labour and delivery, in the same way that it might take you longer to recover from general surgery. And there's no reason why your symptoms will become worse during labour or delivery. So I'll hand you over to Kate now for the next few slides. Thank you, Kate.
Thank you very much. And thank you so much for inviting me to do this, Amy. It's an absolute pleasure to be here with you this evening. I apologise for the slight disruption in the background. That was, I think, my children managing to break my door. So one of the questions that I think people are really interested in knowing about is will pregnancy affect your MS activity? And I suspect lots of you have heard about the fact that pregnancy is relatively protective against the risk of relapse, but there's a risk of relapse in the postpartum period. And that in historical kind of pre-treatment era was completely right. So this graph that you can see, the kind of black and white graph, is fairly old data from the late 90s. And it does, and up the side, on the vertical axis, you've got the number of relapses per year, and then the trimesters of pregnancy across the bottom. And you do see a reduction in relapse rate during pregnancy, but then it jumps up after pregnancy. And what we see in the more colourful graph is an overall reduction in relapse rate as we're using more highly effective treatments, and a less dramatic kind of reduction during pregnancy, I think, which reflects the way the fact that we're kind of treating MS better overall. There is a slightly increased risk of relapse in the postpartum period, and we'll cover a little bit about how that you can reduce that risk. And I think it's worth noting that this is still not, we're looking at 2011 onwards, so this will include women that were either treated with moderately or slightly lower efficacy drugs than perhaps the more modern drugs that we're using these days. So I think there's lots of decision. I'm going to talk a bit about basically the disease-modifying therapies and how they're relevant to family planning and pregnancy. And I think DMT decisions are difficult anyway, aren't they? And I've kind of demonstrated all the different factors that we might bring into play when we're deciding what disease-modifying therapy we might want to be on. And then it actually circled in blue. They should have been circled in red, but the ones that are particularly relevant is your family planning. So we do want to think about drug safety. We want to think about perhaps your age and your fertility, although we've discussed how MS itself, all the drugs shouldn't affect that. But it might be that you don't want to wait around, as people have been told in the past. And then we have to think about the impact if you were going to stop the disease-modifying therapy to get pregnant or during pregnancy. And that's alongside all the other things in terms of eligibility criteria, how active your MS is, the mode of delivery of the drugs that you're having. So this is a leaf that I wanted to point out to you that's available from and was produced with the MS Pregnancy Register and along the UK ABN consensus guidelines. So the ABN is the Association of British Neurologists, and it lists all the disease modifying therapies, all the ones at the time, and whether or not we would recommend that they were given during pregnancy, up to pregnancy, and about breastfeeding. And I'm going to go through it. You don't have to, you can take a screenshot of that, but I'm going to go in that in a little bit more detail in each individual drug. So getting to the nitty gritty, the drugs that continue through pregnancy. So most medical teams and MS teams are very comfortable with continuing the first line injectable therapies, interferon and glatiramer, so that's Copaxone and Brabio, throughout pregnancy. And I think that's fairly accepted common practice these days. The other drug that we are increasingly confident in using throughout pregnancy, and I have a number of natalizumab babies, well, not I personally, but my patients do, and that is natalizumab. And the reason that I think we started using this during pregnancy is because there is a significant risk of rebound if we stop this drug for pregnancy. And there is increasing safety data that there is very little risk to the unborn child if it's continued through pregnancy. We tend to extend the interval dose through pregnancy. So traditionally this is given 4 weekly, but can be given 6 weekly. So we would give it 6 weekly through pregnancy and ensure that the last dose is given before 34 weeks. And if the last dose is given before 34 weeks, kind of accepted practice is that there's no need to do blood tests on the newborn baby. There's very little risk of any problems with the baby's blood when they're born. So what about drugs that we think you should stop whilst trying to conceive? So there are a group of drugs which I would recommend stopping a short period before trying to conceive. And I think this is a challenge because we all recognize that you're not necessarily going to get pregnant the moment you want to. And so I think this is where the challenge lies. But these drugs I've listed here, so fingolimod, which is a second line oral treatment for MS, we would generally suggest stopping 2 months before stopping your contraception. Siponimod, slightly less, so 10 days. Ozanimod, which we don't use in the UK, but is sometimes prescribed in Scotland. The advice is to stop it 3 months before trying to conceive. And ponesimod, just stopping for a week. I don't know about you, Daisy, in your team, but I generally avoid starting these drugs nowadays. Historically, when we had a lot less options, we do have younger women on fingolimod. But these days there are other options, and so I would generally avoid using these drugs if there is a plan for pregnancy in the next few years. So a brief mention about caraflutamide, which again is a drug that I would very rarely use in women of childbearing age. It has been shown to be harmful in animal studies, and you really need to stop it. It's had long half-life, so it hangs around your blood for a long, long time. So we would recommend stopping it for 2 years, or there's an accelerated washout period, and we would recommend that before trying to conceive. It's also not recommended in breastfeeding. So again, it's a drug that I would just avoid in women who are at any point planning to be pregnant. Dimethyl fumarate is a much more commonly prescribed oral treatment for MS. And the data regarding this in pregnancy is really encouraging. There hasn't been an association with adverse events in pregnancy or in infants exposed in early pregnancy, and that's looking at pregnancy registry data. We don't generally recommend to continue it during pregnancy because there isn't enough data to say it's completely safe. But if your kind of disease activity is relatively low pre-pregnancy, their options are to either switch directly to an injectable therapy, or you conservatively might be to stop it 2 months before trying to conceive, or even stopping at the point you get a positive pregnancy test. And depending on your disease activity, you may wish to switch to one of the other drugs, which we're going to come on to talk about in a second. So it's worth mentioning something called the induction therapies. So you might have heard about the drug called cladribine, which has been in the news recently because it's recently had its license. It's not a new treatment, which I think a lot of the newspaper articles made it out to be, but it's had its license changed. So we can now use it, and we'll now be able to use it in a lot more people because we can use it after a single relapse. So that's going to be really useful. So it's a treatment that's given 2 years. It's an oral treatment given 2 years apart. And so you're not having continually an ongoing drug. We do recommend that people take precautions and don't get pregnant for 6 months after the most recent dose, and that's men and women planning to conceive pregnancy. So that's really important to be aware of. But obviously, once you've had your 2 courses and 6 months after your second course, you're not taking a drug, and so there's no restrictions and there's lots of pregnancy planning opportunity, as this graph demonstrates. So another induction therapy, which some people may have received in the past, is a drug called alemtuzumab. Now, this is a drug, and I think Sheffield are probably quite similar to my practice, that we used quite a lot when the license was less restrictive, for the very reason that it's very attractive in terms of pregnancy planning, because it's, again, an induction therapy, 2 courses given 12 months apart. The advice is not to get pregnant until 4 months after your last dose, but then you're not having an ongoing treatment, and you're free to pregnancy plan around that. And so I've got several, I've got lots of people we use that on for this very indication. We do still use it now, but the eligibility criteria are much stricter, so you have to have had 2 relapses in a short period of time. So I think the big pops one to talk about is the B-cell therapies, so also known as anti-CD20 therapies, and the ones most commonly used at the moment are ocrelizumab or Ocrevus or ofatumumab, which is Kesimpta. And we've got coming up, ublituximab, and I'm sure there'll be more to come. So the advice that we give to people, and the ABN advice and the kind of MS scientific advice, is more relaxed than the drug company advice. And I think this is where some of the confusion comes in, because if maybe advice is coming from a general neurologist who's read the inserts, then the formal advice is that it used to be that you had to wait 6 to 12 months before trying to conceive. But actually, there is very little risk, and I'll come on to some evidence for this. There's very little risks, even if you start trying to conceive immediately after having your last dose. And that's to do with drug kind of mechanism of action and crossing the placenta, and when drugs are across the placenta. So, common advice would be to stop contraception 1 to 3 months after your last dose. But I say to my women that you can probably start trying as soon as you've had your infusion. And then if you hadn't got pregnant by 6 months, you would have another dose, and then you can start trying again. We don't generally give during pregnancy, although you could if it was absolutely necessary. But we would restart it as soon as possible after birth, and that is to prevent that postpartum relapse. The other good thing about ocrelizumab is it has quite a long kind of duration of effect. So even if we know that people have it every 6 months because that's what the license is, but the duration of effect, so it's likely to be effective for a lot longer than that. So it's likely to have an effect throughout that duration of pregnancy. Ofatumumab is very similar. So the cautious approach would be stop for 3 months. My advice generally, I don't know if Daisy's got anything else, but would be to continue until pregnant with ofatumumab. And the alternative, again, I have some women who I would say, well, look, because of the longer duration of action of ocrelizumab and the very similar kind of mechanisms of action, that we could give you a dose of ocrelizumab, which is likely to see you longer through the pregnancy, and then you can switch back to ofatumumab after you've had your baby. So that's one approach that we use as well. And I'm sure there'll be more questions about B-cell therapies and pregnancy. A bit of data just to back up what I've just said. So this was data from the biggest registry of pregnancies of ocrelizumab, and this was presented at the big MS meeting ECTRIMS last year, and they have data from 575 babies, almost half of which were exposed in utero. So women was given ocrelizumab during the pregnancy. And the encouraging thing is that there was absolutely no signal of increased risk of negative outcomes in the pregnancy or the babies born. So I think that's really encouraging data. So what about breastfeeding myths? And I think this is probably even harder to navigate for some people than the kind of pregnancy myths. So, you know, I'm sure we've come across women who've been told that they shouldn't breastfeed. And certainly I think there are lots of women that are told they shouldn't breastfeed whilst taking their disease modifying therapy. I think there is a lot of perhaps hope that breastfeeding, if you exclusively breastfeed, will prevent relapse. And we may be coming on to this a bit again later, and there is some data to suggest it's relatively protective against relapse, but not completely. So the breastfeeding facts is that I would absolutely support a woman to breastfeed if they wanted to and if they're able to. And I think it's important to note there are other reasons why women might not want to breastfeed. And I always say fed is best. I think obviously there's lots of reasons why breastfeeding is good, but obviously having a well-fed baby is the most important thing. There is, as I said, a potential association with a reduced risk of relapse postpartum, but it isn't effective if you've got highly active MS. And it is also important to restart your disease-modifying therapy as soon as possible postpartum to reduce the risk of relapse. And that's probably going to have a bigger effect than exclusive breastfeeding. But as I've just said, there's no reason that you can't potentially do both. So in terms of the disease-modifying therapies and breastfeeding, again, it's a bit like pregnancy. So the interferons and Copaxone, glucosamine, would continue through breastfeeding. They're big molecules. They're not likely to get significantly into breast milk and then get into the baby's blood. So even if they get into breast milk, they're not going to be absorbed. The reason we inject them is because you can't absorb them orally. However, orals we don't tend to recommend because they are small molecules. They are more likely to get into the placenta, get into the breast milk, and then get into the baby's blood. Again, monoclonal antibodies. So by that I mean the natalizumab, which is Tysabri or Tyruko, alemtuzumab, ocrelizumab, and ofatumumab. They're large molecules. They're inactive when orally absorbed, and that's absolutely safe to continue breastfeeding whilst you're having these drugs. And again, if you don't believe just me saying this, there is data, again, present to ECTRIMS last year, where they took the breast milk and looked at the breast milk of mothers that were receiving ocrelizumab and found that there were negligible levels of ocrelizumab in the breast milk. But if you're not satisfied by that, they also took the blood of the babies and found that the ocrelizumab was not detectable in their serum. So it's a relatively small study, but with fairly consistent results across those mothers and babies. So I think just coming on to the other side of things is that something we often forget to talk about when we're giving these kind of talks is symptomatic treatments in pregnancy. So everybody manages pregnancy with or without MS in a different way. And some people feel wonderful, but some people find it a really challenging time. And, those symptoms of MS may get better, but they may get worse, or they may stay the same. But you may want to think about that if you're running need symptomatic treatments for MS, whether those can be continued through pregnancy. And so I put a kind of list there and I color coded it. So the ones in green are the drugs that we have most confidence in continuing through pregnancy. The ones in orange are the ones where there's a bit less of the kind of a finer balance between risk and benefit. So if your symptoms are severe enough, you may want to continue with the treatment. And then the red ones are ones that we would tend to recommend avoiding continuing during pregnancy. So amitriptyline is probably one of the safest. Again, it's one of the safer drugs that we use for migraine during pregnancy. Whereas carbamazepine, duloxetine, and gabapentin, you may have a bit more caution about, and pregabalin we would probably try and avoid. With spasticity, similar baclofen, there are some concerns, but it could be considered if the spasticity risk was outweighing the kind of risk to the baby. But clonazepam and diazepam probably safer options and could be used short term. And fatigue, unfortunately, both the fatigue drugs, which we probably don't use very much anyway, but wouldn't be recommended to continue through pregnancy. So actually, this I think probably is the most important take home from our talk is if you do get pregnant and you're pregnant and with MS, that I would absolutely encourage you to register that with the UK MS Register, because the more information that we have about women with MS having babies is the more kind of information we can give back to you in terms of safety and outcomes. So this is really vitally important. So there's a link there. And I'd encourage you to kind of have a look. And they have lots of, though I met the girls at the MS Trust conference just yesterday, and they're developing a new website where there'll be even more information on it. So I think it's a watch this space. And then in terms of other information regarding other medications, I haven't, I'm sure there are other medications that people may be concerned about. And this is a brilliant resource where you can look up pretty much any medication and look at the evidence and the advice of whether it should be considered during pregnancy. And so I use this quite a lot in my practice. So I'm going to hand back to Daisy now, who's going to talk about kind of postpartum issues.
Thanks, Kate. So what we look at pre-pregnancy, I'll just touch on this, and I'm very, very aware that it's very different around the country. In Sheffield, we run a preconception clinic. So we encourage all our patients of childbearing age, male and female, to, if they are thinking about pregnancy, to let us know, and we will see them in our pre-pregnancy clinic, in our preconception clinic. We also run and that's myself and one of the consultant neurologists and one of the consultant obstetricians. And we also run a pregnancy clinic, which are the same three of us, so nurse, consultant neurologist and consultant obstetrician. We found these to be really effective, and women feel very supported, and they don't have to take the information around to different clinics, and everybody knows what's happening. So what we look at in the preconception clinic is the number of relapses, because what the feeling is that the predictors of you having a relapse post-pregnancy is very much on your history before the pregnancy. So we know that approximately about 14% of ladies do have a relapse in the first 3 months following delivery. But we also look at how many relapses they were having before they got pregnant. If they've had previous pregnancies, have they had a relapse during any previous pregnancy? We also look at how active the MRI scan was prior to conception. And we also look at the EDSS score at conception or preconception. So that's the score that we use to assess whether, about disability and, whether you're completely okay, whether you're needing 1 stick, 2 sticks, etc., etc. We also look at what treatment you're on prior to conception, and obviously if the treatment that you're on is not safe to conceive on, we would switch you onto something that was safe and counsel you on that. And we know that discontinuing fingolimod and Tysabri natalizumab will potentially lead to a rebound relapse post-delivery, which is why we now continue with Tysabri up to 32, 34 weeks of pregnancy and aim to restart you on that treatment within 2 weeks of delivery to prevent that happening. We know over the years that the early restarting of your DMT after delivery is the most important factor to prevent a postpartum relapse. So it's absolutely vital to let your MS team know once you have had your baby, so the treatment can be recommenced as soon as possible. All this information was written by a lady called Kirsten Hellwig, who's at the bottom there. She's the guru of all things pregnant and conception-wise. She's German, and she's done hundreds of papers, well, not hundreds, but a lot of papers on this topic, and her knowledge is amazing and her research is amazing if anybody ever wanted to look into her. So that's where that's from, and that's the model that we certainly use in Sheffield, but I am aware that it's not the same everywhere. So how do we manage a relapse during breastfeeding? So if you felt you were relapsing, obviously you'd need to be seen and assessed. If it was if you were having minor symptoms and the symptoms weren't interfering with your daily activities, we would probably not treat it and watch and wait in hope that it would settle. You can feel that you're having a relapse sometimes postpartum because you're just so exhausted. And it's really difficult to say whether that's the MS that's causing that, whether it's just having a new baby and having absolutely no sleep, whether it's a change in your hormones, whether it's, the stress of restarting on a treatment. So if your symptoms were minor or not really interfering, we would probably not treat it. But we can treat more severe relapses with methylprednisolone. We know that overall, steroids in general are low risk for use in pregnancy and breastfeeding. And we also know that methylprednisolone, which is what we tend to use for a relapse, we know that those levels drop significantly 4 hours after the infusion. So what we say is that if you are breastfeeding and you do require methylpred, we would encourage you to pump and dump for the first 2 to 4 hours after the infusion, just to limit the baby's exposure. But overall, the message is it is okay. If you're needing methylpred, then we would be happy to give you that, knowing all the safety data. So managing MS in general before, during, and after pregnancy. So what we would say, what we would advise is contact your MS team for advice and support if you are planning a pregnancy. Obviously, if the pregnancy happens and it's not planned, which a lot of pregnancies are, again, contact the team, let them know you're pregnant, and they can advise regarding treatments and reassurance. Again, like I said previously, let them know as soon as you've delivered so we can get you restarted on your treatment without delay. Follow the advice given regarding any medication, and that's MS medication, general medication, DMT medication. So just follow advice regarding that. As I said, there is a huge variation in MS services and particularly MS maternity services across the UK. But what we would say is if you don't have a joined up clinic, then it's really important that each specialist clinic is speaking to the other specialist clinic. So what I would say is take everything with you. So take the details of your maternity team to your neurology appointment. So the neurology consultant or nurse knows who to write to and communicate with in regards to the pregnancy. Take your neurology team details to your pregnancy clinics so they know who to ask advice from. So, try, it's really important that everybody talks to each other, and I hope that that is happening more. But if you're in an appointment at either maternity or neurology, I think it's completely okay to say, will you be writing to my neurologist? Will you be writing to my maternity team? And then everybody knows what everybody else is doing. And often we can learn from each other. So I've learned so much from the maternity side of things, from doing the joint clinics. And, I think maternity have learned a lot about MS as well. So the more joined up it is, the better. And just communication is key. Also, restart your treatment as soon as possible, ideally within 2 to 3 weeks. That may vary. Obviously, if you've had a cesarean, you need to be infection free. So your scar needs to be healed and you need to be well otherwise in order to restart your treatment. Accept all offers of help postpartum. Don't be a hero and try and do everything. Having a baby is exhausting, and the more help you take, the better. And ask for help if you're struggling. Ask the advice of health visitors, support groups, family, friends. There's also local and national support groups, particularly postnatal support groups, but also the MS groups that I'm sure you belong to. And post-pregnancy is managed in exactly the same way any other post-pregnancy is. So there's nothing that you need to do. There's no extra checks you need to have. What we tend to do in Sheffield is once our ladies have had their babies, we do like to do an MRI scan, usually about 6 months after they've had their baby, particularly because if they have been off treatment or had a pause in their treatment, we just want to check that nothing's changed during that time. But apart from the MRI scan, there's no differences between your pregnancies and the general population. So, family planning options after childbirth and whilst managing MS symptoms. I think obviously when you're pregnant, discuss with your obstetrician, your midwife, whilst you're still pregnant about post-delivery contraception. It's obviously a completely individual choice. There's no recommended contraception that's recommended because you have MS. It's whatever you feel is best for you. And obviously make sure that if you're on a particular DMT that you shouldn't get pregnant with, then make sure that the contraception you're using is 100% safe. Okay, so other considerations in general, just the sort of take-home message. MS itself does not increase the risk of birth defects. You should all be taking vitamin D every day from now forevermore. Folic acid, whilst you're trying to get pregnant, you can stop this at the end of the first trimester. So at the end of your first 3 months of pregnancy, you can stop the folic acid but continue with the vitamin D. MRI scans are not contraindicated if you need one during pregnancy. MS is not hereditary, although there is an increased risk, 1 to 2%, if from a relative of somebody with MS compared to 0.3% of the general population. So it's not hereditary. You're not going to pass it on to your child. And vitamin D supplementation in children is something that we encourage also. So any children you currently have, any children you're going to have, get them on vitamin D for life. Okay, so summary of facts that we've discussed. Family planning should be considered when making decisions on a disease-modifying therapy you choose. It's no longer routine to stop all DMT treatments prior to conception. Advanced planning is key, it's vital, and especially as it may require you to switch your DMT to one that's safe to have during conception and pregnancy. The stability of the disease activity prior to conception is associated with reduced risk of postpartum relapse. And breastfeeding should be encouraged if possible, but it is obviously your choice whether you do that or not. So I think that's the end of us rambling and time for questions.
That was brilliant. Thank you both. And actually, a lot of the questions that were coming through, you were kind of ticking them off as we were going. So that's brilliant. So we do still have lots of questions and we've got 15 minutes. So where do I start? The first question is kind of around a typical pregnancy with MS. So, can you walk us through a typical pregnancy with MS? What does a set of scans slash checks, etc., look like? And is there any additional monitoring for mother and baby? I think you answered this quite well, Daisy, in the slide about managing MS before, during, and after pregnancy. But I just wondered if there was anything else you would add to that or UK.
Not from my perspective. I mean, MS pregnancies are treated in exactly the same way as any other pregnancy. As I said, you don't need extra scans, you don't need MRI scans. You need to be on a safe treatment, DMT treatment. But apart from that, there's nothing, we don't treat MS pregnancies as anything special or different to anybody else's pregnancy.
Brilliant. Thank you, Daisy. Anything else from you, Kate, for that one?
No, I totally agree. I was going to say, I think, I sometimes the first time I realize that somebody's pregnant is because I've been written to by their obstetrician or midwife, and they do usually ask me, is there anything that we could or should be doing? And just as Daisy said, and it's a very simple letter for me to write because I just write back and saying, that's fantastic, congratulations, but there's no reason to treat this pregnancy in any particularly different way.
Brilliant. Thank you. That's very reassuring, I'm sure. Another one that you pretty much answered, but there's a little bit more that I just want to ask. So, obviously, you said that a way to help with the risk of relapse after pregnancy is to restart treatment as soon as possible. So, does that mean you can start pretty much any of the treatments as soon as you've kind of given birth? Or is there any kind of
You
way?
want to some of the I'll let Kate answer this. Some of the tablets, no, but yes, Kate, you answer that.
I mean,
Dr.
yeah, I mean, I
Kate.
think so. Yeah, it depends on your breastfeeding and the type of disease modifying therapy. So, as I said, we wouldn't recommend breastfeeding with most of the tablets. But for the infusible, so we have been known to kind of infuse people on their way out of the door from maternity almost. So, and I suppose the only caveat to that is, as Daisy said, if you've got an active infection, so if you've had a cesarean, or have got a kind of infection postpartum, then we'd probably want to see that cleared before giving. But again, it depends a little bit on the treatment, because I'm pretty relaxed about natalizumab unless you've got a really bad infection. So yeah, no, there is very little that would stop me giving somebody a treatment, and which is why it's so important for us to kind of know if you're having, because I mean, we've got quite a lot of capacity on our infusion unit, but I know other centres don't, so there may be issues in terms of capacity infusion units. So yeah.
Great.
The sooner the better, really, I think,
But the
is
sooner the
the
better.
take home within reason and within each individual capacity of the units.
Yeah, perfect. And a treatment specific question. So, if your last dose of Tysabri is at 34 weeks, is induction usually suggested to prevent going over 40 weeks of pregnancy and preventing a delay in treatment?
Ooh. I
No, from our clinic perspective, no, we wouldn't induce somebody on those grounds.
think most maternity, I think it's quite uncommon to let people go beyond 40 weeks nowadays, I have
Yeah.
to say. But I certainly wouldn't necessarily use that as the main driver for induction. Obviously, a natural delivery is better, I think. So yeah, I mean, we would certainly, I'd be happy to have discussions with obstetric teams in that situation.
Yeah.
But yeah, I haven't come across that in my practice yet.
No problem. Thank you. And are there any treatment considerations for men when thinking about starting a family? So kind of anything around fertility, and treatments that might affect that?
Do you want me to take that, Dave?
Yeah, you take that one, Kate.
The main one is cladribine. So as I said, and I think this is one that's really important. So men who have got MS and are going to be taking cladribine should be advised to use contraception for 6 months after the most recent dose.
Yeah.
But I'm not aware of any adverse effects on fertility in men with any of the disease modifying therapies.
Okay, perfect. So a bit more about fertility, and kind of IVF. So we've had a few questions about that. So is there any evidence around MS and egg retrieval prior to IVF? And another question, IVF, will it matter that I have MS?
The second question I can answer. The second question, no, what we recommend to all our ladies is, regardless of the fact you've got MS, if you've been trying to get pregnant for a year and nothing's happened, your first point of call is your GP. Your GP will do the basic fertility tests, so blood tests, sperm count, and then if appropriate, if necessary, your GP will refer you to the fertility services. But having MS is irrelevant. It's whether you can get pregnant a year or longer. If you've been actively trying for a year or longer and nothing's happened, you're absolutely, regardless of your age, because we had one GP telling a patient of ours who was only 24, 25, and she'd been trying for 4 years, and the GP said, you're far too young, which is absolutely incorrect. But again, it's different doctors, different nurses. So from a fertility point of view, MS doesn't affect that, as we've said. And if you've not got pregnant within a year, then go to your GP and insist on asking for some fertility tests. I will leave the egg retrieval to Kate.
Thanks. So I'm not a fertility expert. I will put that out there as a caveat. But I think there used to be concerns about some of the drugs that were used in drug stimulation and that them risking MS relapse. Modern data doesn't bear that out. And so with the kind of there's no evidence that any form of IVF or enhanced conception significantly increases your risk of MS activity. So having MS doesn't preclude you from any type of IVF. That would be my take home.
Brilliant. Thank you both for that. Um, we're getting through these questions quickly. Quite a specific question again. Is it okay to continue Brabio if you have a C-section and wound is infected?
I would say yes, unless the infection is rip-roaring infection that you need to be admitted into hospital with. If it's just a C-section wound infection and you're on antibiotics, personally, I would say yeah, continue on the Brabio throughout. Yeah, would you agree, Kate?
I would totally agree. I think, because it's again, it's got quite a long duration of action as well. So I think, and this is, I think, a misconception that is in a lot of kind of immune modulation and suppression, is that often these drugs last a lot longer than you stop them. So there's often very little benefit stopping them when you've got an infection that's going to be cleared within a couple of weeks. As long as it's not, as Daisy said, a life-threatening infection, yes, that would be a reason to stop. But a mild or moderate infection, even if it requires some antibiotics, I would continue most treatments throughout.
Brilliant. Thank you. Another question. Do you know if milk production is affected after infusions?
Not that I'm aware.
Not that I'm aware of. I don't think there isn't a mechanism by which I think it would be. I suppose otherwise, you know, some people do feel tired and fatigued after an infusion, and that might affect milk production, but there isn't a biological reason for the drug itself that would affect milk production.
Great. Thank you.
I suppose one thing to say
Yeah.
just on the ocrelizumab and breastfeeding is that we did talk about steroids and perhaps avoiding breastfeeding for perhaps 4 hours, and I think it's worth reminding that you do get a dose of methylpred if you're having an intravenous infusion of ocrelizumab. So it might be worth pumping and dumping for the 2 to 4 hours post an ocrelizumab infusion for the steroids rather than the ocrelizumab. I don't know if that's something that you would recommend, Daisy.
Yeah, we say yeah, 2 to 4 hours. Just don't breastfeed because of the steroids, not because of the
Yeah.
ocrelizumab, but because of the steroids. Yeah.
A slightly separate question, but linking to what you've just said. So, are there any alternatives to methylpred? Someone has said that they don't really get on with that.
For a relapse or for ocrelizumab? We don't know.
We don't know.
Um, so in terms of relapse treatment, not really. Like Daisy said, I tend to usually only give steroids for kind of really disabling relapses. We know that steroids aren't going to alter the outcome, the eventual outcome in MS. So if you can get away without steroids, then I think it's perfectly reasonable to do so. And I think if we're talking about giving it with ocrelizumab, then I think you're most like the reason we give steroids is to try and reduce the infusion reaction.
Mm-hmm.
And they're most common the first infusions that you have. And I know that some centres have given ocrelizumab without the steroids successfully. So that could be an option to discuss with your team. The other thing to say is that subcut ocrelizumab, which some centres are starting to use, you give an oral dexamethasone rather than methylprednisolone. It's still steroid, so it'll have a lot of the same side effects, but you may be able to get away with a smaller dose. But I think that would probably require a discussion with your team and an individual decision. Would you agree, Daisy?
I do agree. Yeah, I do agree. Yeah. I mean, all that methylprednisolone does is just speed up the recovery of the relapse. It doesn't actually cure the relapse as such. So, with or without methylpred, you will recover. It can just take that bit longer without the methylpred input. I mean, I think, the main thing with any sort of relapse or the start of a relapse, if you feel like you're in those first stages of relapse, is resting. And I know that's easier said than done, especially when you've got small children and a baby, or you're working. But that is the vital, because just by having a few days of resting, that can be enough for those symptoms to lift before you require anything like methylpred. But yes, I agree with Kate. I need to stop talking.
Never stop talking, Daisy. It's great.
Amazing. Thank you so much. I think we have managed to answer the majority of questions. There are a few still outstanding, but a lot of them are kind of about breastfeeding and some of the things that you both covered earlier. So it might be that people joined a little bit later. So I would definitely recommend going back and watching the recording that will be available on our YouTube to get answers to those questions. And also do get in touch if you have any other burning questions. But that brings us to the end of the webinar. A massive thank you, Kate and Daisy. It's been so informative, and I think everything that you've given us tonight. I know it's been a quick whistle-stop tour, but it's exactly what we wanted to give, just to help to educate and empower people living with MS to make informed decisions about family planning. And it's been so helpful. And there's loads of comments in the chat. I don't know if you can both see, but just saying how helpful it's been. So thank you both so much. And yeah, the recording will be available on our YouTube probably tomorrow. So thank you so much for joining, everyone.
Thank
And
you.
yeah, there's loads of comments in the chats for both of you just saying thank you and how helpful it's
Thank you.
been. Thank you so much,
No
everyone.
problem. Okay,
Have a
cheerio.
good
Have a good
evening.
evening, everyone.
Thank
And
you.
you.
Bye.
Bye.
Bye.